We'll move on to our expert panel on the early childhood. This emphasizes more than everything the frustration that we're not meeting together on the stage, but we'll meet our friends along with my colleague to presenting this panel, Dr. Yuda Kohler, and I'll introduce Dr. Michal Begin. She's a developmental pediatrician and the director of the Child Development Center of Leumit Healthcare in Jerusalem. My friend, Dr. Aviva Bloch, who's a child neurologist and developmental pediatrician. She's a director of the Pediatric Neurology and Developmental Unit of Lowenstein Rehabilitation Hospital in Ra'anana. And she's a senior lecturer at the Sackler Medical School at Tel Aviv University. And Dr. Gal Meir, whom you met before, he introduced me, and now I have the honor to introduce him. He's the head of preschool psychiatric unit at Soroka University Medical Center, and the clinical director of the National Autism Research Center of Ben-Gurion University. So thank you all for participating, and Dr. Kohler will introduce the topics of our panel.
So we're thrilled to have this wonderful and esteemed group of people together. The goal of this panel is to bring the perspective of the people leading the work in the community in an attempt to support young children with autism and their families. Over the last decade, we've seen significant advances in research related to early identification. Dr. Begin, would you start us off by describing some of the general challenges that are still faced in the community related to early diagnosis?
Okay, so thank you, first of all, Judah and Lydia, for inviting me to participate in this panel. I think that with the really very large body of knowledge that we have gained in recent years, my team and I in the center feel very comfortable giving a diagnosis of ASD to very young children, definitely younger than years before. But this will probably cover about 70 to 80% of the kids that we see. I think that one of our main challenges is on the spectrum, the kids are on the sides of the spectrum, where the kids will probably 10 to 15% of the kids who show up, and they really are in a gray zone. And the younger they are, and when the symptoms are subtle, the harder we find, or the more difficult it is to give a diagnosis that we are not sure of, and we are not sure where the child will go in the next few years. And I think that while most children do come in with red flags that are quite clear, the challenge is in two areas. One is the children who come in very young and who are cognitively intact and who may have language and do have some play and do some showing and giving, but it's mostly the quality that is not fine. It's not a lack of doing things, but rather a qualitative issue. And on the other side are the children who are very low functioning, who have cognitive issues, who may look syndromatic, and where we're not sure for quite a few months and maybe even a few years if what leads their difficulties is their cognitive or cognitive issues or the autistic features. And these are the children that we find most challenging these days. But for most of the children coming in, even at very young ages, I think that we feel comfortable with the tools that we have, with the questionnaires that we have to give a diagnosis these days.
Gal, in your unit in Soroka, you work among other populations. You work with a very particular population. You have a lot of experience and expertise in working with the Bedouin community. So I'm wondering if you could relate maybe to the notion of early diagnosis or challenges in diagnosis in that community specifically, and maybe more generally in socio-demographic minority groups.
Yes, I think this goes along with the first lectures the wonderful talk of Professor Ami Klin. He mentioned at the end of his talk about the minorities in United States and what happens with the Black population, kids that are late diagnosed. I think we had the literature is the same as we see in real life in minorities in Israel. In the Negev, the Bedouins are about 270,000 people. And half of the laborers in Soroka University Medical Center are of Bedouins, but we see less than we expect kids that are referred due to suspected ASD. So actually, we initiated years ago a project with the Ministry of Health because we did see that we do not have referrals from the Bedouin community. And we were able to see that once we raised awareness and we recruited professional people and we were more culturally sensitive, we were able to screen and diagnose more children with ASD. And we were also able to show that when the project progressed, we were able to decrease the age of diagnosis. So we do have a lot of work to do because we are still think that we are underdiagnosed. And another thing that we are able to see in the way we diagnose today and with the better referrals that we see today is still the fact that we see the more severe cases of autism with comorbidity of intellectual disability, and we see less cases of mild to moderate autism with normal cognitive functioning. So we still have a work to do with raising awareness in the community and with professional people, so we can also screen better and diagnose better for those kind of kids.
It's such important work. If I were in Zoom, I would make the clapping emoji because you guys are really doing remarkable things in that community. Aviva, over the last year, there have been countless challenges in society on every level. Could you talk about how the pandemic has impacted the field of autism diagnosis based on your experience?
Thank you very much for inviting me to the panel for this wonderful conference. Yes, the pandemics of the COVID-19 has been a terrible challenge, both for the families and for the teams. Families have been facing extra worries, not only about their child that has problems with developing, but health problems, health worries, finances problems. Some of the people had to adapt to working at home with the children around, isolation, lack of grandparents' support. The lockdown was putting a lot of stress on the families. Children could not even go to park. The family could not go out. And then kindergarten were not working. And from one point of view, sometimes there was less need for social interaction for the children. And there was not the eye of the teacher in the kindergarten giving us sometimes some very critical information, or sometimes pushing the family to go to be diagnosed. There were special problems also for families having already one child being diagnosed ASD and being at home with all the difficulties and being worried with another child needing to be diagnosed. And then coming to the centers was very often not possible. The parents were either worried to come to the centers or not able to come to the centers. And the teams were sometimes not able to come to their centers because they were with their children, and etc., etc. So there were terrible extra stresses on everybody. There have been already before the pandemic developing of telehealth systems helping in the diagnosis of ASD. Some programs were developed before pandemics, like the STAT program, the Italian Early Bird Surveillance program, and definitely during the lockdowns everywhere, these programs were really accelerated. And even in Israel, we had quite a lot of centers using these variations on these programs, and trying to do part, at least, of the diagnosis using either video conferences or some storing and forwarding of films, when you could see interactions. And all of us have been trying to develop and to use some of those programs. I could say that in general, most of these programs have quite fair agreement with gold standard normal evaluation, and they definitely help us to reduce some of the parental stress and anxiety when they had some sort of interaction with us, and in some of the cases we could advance the evaluation through using these programs. Now, actually, we are hoping to be facing hopefully the end of the COVID-19 crisis. I'm not sure about that, but I do want to hope that. I still believe that these programs need to continue to be implemented, even if we are after this crisis, because we don't know when we're going to need them again. And also it could be used also for helping people that do not have access to being evaluated in a regular way. I think that maybe from Professor Klim, we heard about some other very interesting ways of doing more screening or even diagnosing using some new technologies. So maybe the future is here.
Thank you very much, Aviva. Very interesting points, and congratulations also on your recent publication about attitudes of professionals towards this change in the way that we address children. And also, I think you are talking about the end of the epidemics, but we all start to realize that we're probably facing the post-COVID-19 epidemics of developmental disabilities and things that during this year were enhanced, and then we need to be aware of. Thank you all for addressing all those.
If I can say something more, if we have a few minutes. I mean, when we prepared ourselves to this session, we weren't sure if we can talk about everything. I just want to mention that there is a debate about the virtual hybrid telemedicine, and I think that most of us as clinicians will prefer to see the child in the room. And then when we had this pandemic, we faced new reality, and we really had many times to decide if we prefer to see the child with some big limitations, or to wait for the next second to end, or to try to progress with the diagnostic procedure in order to help the child and the family to get services. So I think in the real life, everybody did his or her local adaptations. For me personally, we never were forbidden to see patients. So for me, professionally and personally, I tried to see as many patients as I could in my clinic, in my room in Soroka. So, and I know that others, I think it was also an opportunity to develop technology and virtual medicine, but I still prefer to see the patients in my room, and I think that in this way my diagnosis is more accurate.
That's also telemedicine, the ring of the phone, and also you can think about the ultrasound that I showed as the first telemedicine tool, maybe. So we try to realize the pros and cons, but I'd like to discuss a broader question and another controversy, whether you can see any detrimental effects to early recognition or early diagnosis.
To Michal, or
I think Gal is...
דוקטור גל, המיקרופון שלך סגור.
Sorry, I'll try to answer this question and to start the discussion about it. So many times we get referrals at a very early age, sometimes from parents' awareness, or they have another sibling, another child at home, and they are starting to really watch carefully when he's even before 1 year old, and they refer to us, and sometimes we see some of the symptoms. Sometimes it's not really enough substantial or really clear about the clinical diagnosis. I'll just mention briefly, all the people here are clinicians. So, for example, when you see a child that is 12 months old, and you look at the B criteria of autism, some of them are like, does he or she have special fields of interest? So it's really, of course, not realistic to judge for this specific criteria when you evaluate a child that is 9 months or 12 months old. So one problem is really to do it accurately, and doing it too early might sometimes mask other things that we need to clear. For some of the parents, once you give the diagnosis, they under the impression that that's it, that's the diagnosis, and if that's the diagnosis, of course, there is the emotional burden for the family about giving the diagnosis. And then we know as physicians that ASD could go along with another neurological or emotional or psychiatric problems. For some of the families, once you give the diagnosis of ASD, they think that's the explanation for all the problems of the child. And even if you go for the medical or neurological part, we know as clinicians that sometimes ASD is related or with comorbidity with Fragile X, or with tuberous sclerosis, or with other neurological syndromes. And once you give the diagnosis, and you do recommend, please continue with the neurological examinations and other follow-ups that you need to do in order to rule out other medical problems. Some of them might think, okay, I have the diagnosis of ASD, now my child will get the treatment, the accurate treatment, and they will not follow with the other examinations that you recommend. That's for the neurological part. For the differential diagnosis of psychiatric problems, I would say that when you see a very young child, you need to think about attachment problems. You need to think about other things that looks alike ADHD. For example, sensory problems, and even sometimes very early ADHD looks like autism. So when you are doing a wrong or too early diagnosis, you might miss differential diagnosis. Sometimes it's comorbidity. Sometimes, of course, you have children that have ASD and also ADHD. But in other times, for example, if it's a difficult attachment problem and the focus of treatment should be a child-parent relationship, or sometimes even involvement of welfare services, if you are giving an ASD diagnosis, you might not give the accurate treatment and accurate services for a specific child.
Thank you very much. Would you like to, Dr. Meiri?
Yes, I would like, please, to have the audience attention also, apart from these important points that Dr. Meiri just raised, that sometimes we have another problem when facing a family very early on, when they come and they are worried about the child being late with his language, or something that they think that there is some abnormal movement, or something that is, they are a bit worried, but not very much worried. And definitely they are not worried, or they don't think that there is a very major problem of development and a very major problem of communication. And in these cases, sometimes we are definitely able to get to the diagnosis of autism spectrum disorder. And we face then sometimes a dilemma, because we think that we don't think we know that early diagnosis is critical, and early intervention is very critical for the child development. And then we want to give the diagnosis as early as we have it, and open the child's door to getting treatment. But sometimes the family is not ready for that. And sometimes when we give this diagnosis very early, when the family is not on board, sometimes the family just run away. And very often I find myself trying to predict, to decide whether the family is ready to get this diagnosis or not. And we're not always able to predict that. Very often we do, and sometimes we don't. And sometimes in these cases, while trying to be very honest with giving the family the diagnosis they deserve and they need, and we believe it's their diagnosis and not for us to be paternalizing and not giving it, sometimes we get to the exact opposite of what we wanted. And then the child is not getting any treatment whatsoever. Whereas if we had given some treatment and prepared the family to get the diagnosis, maybe in some cases that would be the better way to deal with this family. And I find myself sometimes very much hesitating what is the right way to do. And it depends very much when it happens. At least in Israel, we depends on the month. So if I meet this sort of family when I'm in the October-November period, then I may have some time to start treatment in the center and prepare the family, do some sort of preparing, and then giving a diagnosis. But sometimes if we see the family in March, April, or even later in the year, if we want to have the child getting an early intervention that will start in Israel, usually in September, in most ages, we have to rush. And sometimes it works, most of the time it works, sometimes it's not that best for the best interest of the family.
Thank you very much. Very important point. And I think we all realize that not only every child is different, but every family is different. So we need to adapt the process to the family and to the child, and to be more individualized and more precise in the way that we either make or not make an early diagnosis, in the way of speeding up according, as you said, to the time of the year, or doing it in a more comprehensive way, looking at the differential diagnosis that Dr. Meiri mentioned. So it's needed. We really have to be very family oriented in this. Thank you.
So maybe we'll throw out one final question, which actually Ami Klin referred to in the keynote this evening. There's this idea that's gotten more and more attention in recent years, the notion of optimal outcome, based on a lot of work from Deborah Fine at UConn. And so, right, there's this notion that there's a subset of children who will maybe lose their diagnosis, or maybe their symptomatology will improve to the point where a formal diagnosis is no longer warranted. And so Michal, maybe you'd be willing to speak as somebody who's on the front lines, making these diagnoses, seeing these kids developmentally. If you have any thoughts about whether this is something that's expressing itself in the community as well.
So I think, yes, definitely. Same as basing the diagnosis on a lot of knowledge that's in the background. I think we also see the same thing with the trajectories, and we do see children who lose the diagnosis. It's usually gradual, much more gradual than we would think. So a minority of children will probably look much better, or even not show symptoms within 2 years. But for most children, it will take years and years. They will start in a specialized daycare and then move on to a specialized kindergarten, and then we'll have some less support when they start school, and somewhere in middle school, when we'll see them in clinic, if you don't look with a very specialized eye with a lot of experience, they really will look like typical children. And only maybe the parents and us will understand that there is something in the background, and maybe not as friendly as other teenagers, or not wanting to go out as other teenagers, but not repetitive and cognitively intact, and perhaps some mild ADHD symptoms. It will be for a few of the children. We have to agree that I think most of the children do not lose the diagnosis, but they do function better. And I think that's the main thing that at least I try to get the parents on board when they ask, so what's the future holding for this kid? When the kid comes in and, they're 18 months old, or two years old, or 2.5 years old. And I give a diagnosis and I say, look, we know that studies show that about 10% of the children will lose the diagnosis. They will not show any symptoms in a few years. And there's no way for me to know at this moment where your child is going, but we do have to be optimistic and know that this is an option. This is definitely an option, that your child will not have a diagnosis later in life. But the first 2 years will show us the trajectory he's going to be on. And in 2 years, I'll be able to tell you better what the future holds for your child. And I think that's the feeling that I usually get. 2 years later, we are much better at telling the parents, and they also see it. They don't need us to tell them after 2 years. They can see if the child gained function or stayed with many, many symptoms, both of ASD or intellectual disability.
So we have one question that was written in the public chat by someone named Ilan Dinstein. He asks, despite the many early signs, we know that diagnosis in Israel is still pretty late. Half the kids are diagnosed after the age of 3, which relative to many other places in the world, including the US, is actually fairly good, but it's much later than it could be. And so Ilan asks, what is the biggest factor causing this delay?
So I think when we look at the average age, it's misleading. I think we have to look at the average age, and we have to describe it before age 5 and what happens after age 5. Because if we look overall, what happens is that children who were diagnosed very late for different reasons can really pull up the average age. And if we look at children who are diagnosed under 5, I think that most centers these days are making earlier diagnosis. Centers such as GAZ, Dr. Meiri, or Dr. Bloch. We do see children very early on, but there are always children who were missed. They might have been missed because lack of knowledge, less and less these days. They could have been missed because the parents were not aware, or they were very high functioning, or kids who were on the other spectrum. As I said before, the kids who are with an intellectual disability and the feeling throughout the years is that the main issue that they're having, or the main impairment, is the intellectual disability. And then only as the years go by, you can see the autism signs sort of pulling through and leading their disability, and then they get a diagnosis very late on. And so these two groups that are more difficult to diagnose early on really pull up the average age, but it's a different set. There's sort of two peaks: the early peak, which I think we've done much better in recent years, and it's moving earlier and earlier. And there is the late peak, and the late peak now goes on into adulthood, because we diagnose children when they're 2 or 3, and we see the parents, and all of a sudden that parent will go and get a diagnosis, and that really pulls up the age of diagnosis. So I think looking at the average is not the appropriate way to look at appropriate diagnosis. We have to divide it into these two groups and work on the younger children and pulling that age down.
I agree completely on this, trying to divide between those groups. But we still have to admit that we do have some barriers also in Israel of access for education of the pediatricians, and there is still work to do in terms of early recognition of the signs and managing those signs.
Definitely, yes, I agree.
I think that we are doing a lot of big progress, and I think that in the last few years, definitely we're diagnosing many children that years before were not diagnosed. We're getting a diagnosis of ADHD plus language delay, language disorders. I think that in my family, I have sometimes follow-up from the child psychiatrists that see some of the children that were in the different developmental centers early on. And actually, even sometimes when we do look at their files, we see that basically we all agree that it was quite difficult, and I would say in some cases not malpractice, and quite even impossible to give them a diagnosis very early on. So I think we're going to get many more children diagnosed early in the next few years, and possibly some children will still hesitate, and they will still need to be follow-up later on until we can be really sure with the diagnosis.
I totally agree with Dr. Bloch and Dr. Begin. I think first about the two peaks issue, because we do see when kids, especially the ones with a high functioning, you see the social problem more prominent when they are in Gan Chova, kindergarten, but sometimes not. It's not very clear earlier, and then they seem awkward at some point for the teachers, and sometimes also for the parents. I have to say also, we have to be modest about the diagnosis, because we are talking about a spectrum. If I will also relate to the former question, sometimes we do use a temporary diagnosis in those cases that we are not certain about the diagnosis, or when the child is very, very young. So sometimes we say, okay, he have most of the symptoms, he's above the minimal criteria, and we give ASD diagnosis for 1 year. And we, of course, treat the child and see the progress. I think all of us, we are trying to give hope. And I think that literature today, research and our clinical experience give us the permission to give hope, because we see that most of the kids that first we do see, and this is a universal consensus, that once we diagnose early, we intervene early, we see more progress. And we see that most of the kids improves, everybody in his rhythm, or depending on his starting point. And I was, have to say, not many times, but a few times I was in this really moving, for me, emotional moment of really being with a child with a family for years, sometimes even starting from low functioning and very severe autism, going to moderate, going to mild, going from partial inclusion to full inclusion, partial support, no diagnosis. So, of course, this is not all our cases, unfortunately, but there are some really very nice cases that you see this progress. This is also something to explore in our big group of those subtypes that you know that have the potential to really to do this development in a very impressive way. So we need to figure out how to help to each subgroup to progress and to give and to be in her maximal potential.
So
I think it's excellent to leave it at this very optimistic note of mentioning the good outcome and the participation and function that we can acquire. Thank you.
Whoa, even good things have to end. We have just come to the end of our 2 amazing days of our third Israeli meeting for autism research, which was actually the first and hopefully the last virtual meeting. This is the time to thank everybody who contributed to the success of this meeting. The list is very long, so I'll read it in order to not forget anyone. So this amazing 2 days couldn't be done without the support and the help of the following people. First and the most, my colleagues at the Israeli Autism Research Center of Israel, Ilan Dinstein, Gal Meiri, Chava Golan, and Analia Mikhailovsky. The members of the scientific committee of the conference, Sagiv Schiffman, Shlomo Wagner, Lydia Gavis, Judah Kohler, Disa Zachor, Corey Schulman, Evan Elliott, and Ofer Golan. Obviously, the management of the Ben-Gurion University and Soroka Hospital, as well as the people at the Ministry of Science and Technology that gave us the support for this meeting. The people at the event place, Tal, Oran, Pavel, and Sivan, who listened to all our crazy requests and followed our guidelines. The dedicated team in our autism research, there are a lot of research assistants and other people in our autism research that also, in addition to their work at the research, they help us to build these 2 amazing days. And last but not least, Mazal Malka Shelanu, who without her, we couldn't do anything. Everything that you saw in these two last days was under her control. I remind you that you can still visit the poster presentation that is available online in our website. It will be available throughout, it will be always available. You can go and look on the poster and contact the presenters if you wish. And I hope that you enjoyed these 2 days and hope to see you next year in person. So, להתראות בשנה הבאה, ומקווה שנהנתם מהכנס. להתראות.